Dear colleagues, Namaste. Welcome to 10-module course Capacity Building for Infection Prevention and Control in Secondary Hospitals in the state of Andhra Pradesh. నా పేరు రంగారెడ్డి బుర్రి. నేను ఇన్ఫెక్షన్ కంట్రోల్ అకాడమీకి అధ్యక్షుడిగాను, అలాగే యూనివర్సిటీ ఆఫ్ హైదరాబాద్లో గౌరవ ప్రొఫెసర్గాను ఉన్నాను. ఈరోజు నేను ఓవర్వ్యూ ఆఫ్ IPC Policy and Guidelines, translating these guidelines into action at healthcare facilities అనే టాపిక్ గురించి మాట్లాడబోతున్నాను. ఇది 10 లెక్చర్ సిరీస్లో మొదటి భాగం. ఈ ప్రాజెక్టు యూనిసెఫ్, ఆంధ్రప్రదేశ్ ప్రభుత్వం, ఇన్ఫెక్షన్ కంట్రోల్ అకాడమీ ఆఫ్ ఇండియా, అలాగే ఇండియన్ ఇన్స్టిట్యూట్ ఆఫ్ పబ్లిక్ హెల్త్ సంయుక్తంగా చేపట్టింది. ఈ ప్రాజెక్టు యొక్క ముఖ్య ఉద్దేశం ఆంధ్రప్రదేశ్లోని సెకండరీ మరియు మెటర్నిటీ హాస్పిటల్లో ఇన్ఫెక్షన్ల నివారణ మరియు నియంత్రణ గురించి అవగాహన, అలాగే నైపుణ్యాన్ని పెంపొందించటం. ఈ ప్రాజెక్ట్ ద్వారా మన రాష్ట్రంలో రోగుల భద్రత, అలాగే నాణ్యమైన ప్రమాణాలు గణనీయంగా మెరుగవుతాయని మేము లక్ష్యంగా పెట్టుకున్నాం, అలాగే ఆశిస్తున్నాం. ఇక ఈరోజు మన ప్రజెంటేషన్లోకి వెళ్ళే ముందు ఒకసారి క్లుప్తంగా ఈరోజు మనం మాట్లాడుకోబోయేటటువంటి ముఖ్య అంశాల గురించి పరిశీలిద్దాం. మనం ఈరోజు ఈ ప్రజెంటేషన్, ఈ 45 నిమిషాల్లో IPC నిర్వచనం, IPC చరిత్ర మరియు నియంత్రణ లక్ష్యాలు, హెల్త్ కేర్ ఫెసిలిటీస్లో IPC ప్రోగ్రామ్స్ ఎలా సానుకూల ప్రభావాన్ని చూపుతాయి, IPC టెర్మినాలజీ, అలాగే బేసిక్ కాన్సెప్ట్స్ అంటే ఏంటి, IPC కోర్ కాంపోనెంట్స్ అంటే ఏంటి, అవి మోడల్ IPC ప్రోగ్రామ్ గ్లోబల్ నాలెడ్జ్ పూల్కి ఏ విధంగా దోహదం చేస్తాయి అనే వాటి గురించి మనం మాట్లాడుకుందాం. ఇక రమారమి ప్రతి 10 స్లైడ్ల తర్వాత మనం ఒక చిన్న అసెస్మెంట్ చేసుకోవాలి. మీ అందరికీ నా విజ్ఞప్తి ఏంటంటే తప్పనిసరిగా ఆ క్వశ్చన్స్ని ఆన్సర్ చేయడానికి ప్రయత్నం చేయండి. ఒకవేళ మీకు కష్టంగా అనిపిస్తే మళ్ళీ ఈ వీడియోని ఇంకోసారి రివైండ్ చేసుకొని చూసి ఆ ఆన్సర్లు రాబట్టేదానికి ప్రయత్నం చేయండి. ఇక ఈరోజు ఈ ప్రజెంటేషన్ అయిపోయే లోపల మనం ఇక్కడ చెప్పినటువంటి కొన్ని సామర్థ్యాలు మెరుగుపరుచుకోవాలి. వాటిలో ప్రధానమైనవి నేను ఇక్కడ ఈ స్లైడ్లో ఇచ్చాను. ఒక 2-3 గురించి చెప్పాలంటే, మొట్టమొదటిగా మనకి IPC యాజ్ ఎ సైన్స్ అండ్ బేసిక్ కాన్సెప్ట్స్ని డిఫైన్ చేయగలిగేటటువంటి సామర్థ్యం మనకు పెరగాలి. అలాగే మనం IPC గోల్స్ అంటే ఏంటి అనేది అర్థం చేసుకోవాలి. ఈ ఇన్ఫెక్షన్ చైన్ ఏదైతే ఉందో, అలాగే కీ IPC టర్మ్స్ ఏదైతే ఉన్నాయో వాటి గురించి అవగాహన పెంచుకోవాలి. అలాగే వరల్డ్ హెల్త్ ఆర్గనైజేషన్ నిర్వచించినటువంటి కోర్ కాంపోనెంట్స్ ఏదైతే ఉన్నాయో వాటిని అర్థం చేసుకోవాలి. అర్థం చేసుకోవటమే కాకుండా ఈ కోర్ కాంపోనెంట్ని మన హెల్త్ కేర్ ఇన్స్టిట్యూషన్స్లో, అంటే మన సెకండరీ హాస్పిటల్ కానీ లేకపోతే మెటర్నిటీ హాస్పిటల్లో కానీ వీటిని మనం కంటెక్చువల్లీ రెలవెంట్గా ఎలా అప్రాప్రియేట్గా వాటిని ఇంప్లిమెంట్ చేయాలి అనేది కూడా మనం అర్థం చేసుకోవాల్సినటువంటి అవసరం ఎంతైనా ఉంది. ఈరోజు మన టాపిక్లోకి ఇంకా డీప్గా వెళ్ళే ముందు మొదటగా ఒక ప్రశ్న వేసుకుందాం. ఈ ఇన్ఫెక్షన్ ప్రివెన్షన్ కంట్రోల్ అంటే ఏంటి? ఇన్ఫెక్షన్ ప్రివెన్షన్ అండ్ కంట్రోల్ మనం దీన్ని నిర్వచించాలి అంటే దీన్ని సాధారణంగా మనం IPC is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers. ఇదేదో ఓన్లీ పేషెంట్స్కి సంబంధించినటువంటి అంశమే కాదు. మనం హెల్త్ కేర్ ఇన్స్టిట్యూషన్స్లో పనిచేసేటప్పుడు యాజ్ హెల్త్ కేర్ వర్కర్స్ మనకి కూడా ప్రమాదం పొంచి ఉంది. కాబట్టి ఇన్ఫెక్షన్ ప్రివెన్షన్ అండ్ కంట్రోల్ అనేది మన పేషెంట్ల యొక్క భద్రతతో పాటు మన భద్రతకు కూడా సంబంధించినటువంటి విషయం అనేది మనందరం గుర్తుంచుకోవాల్సినటువంటి విషయం. IPC occupies a unique position in the field of patient safety and quality. It is an essential part of the infrastructure of the healthcare institutions, especially the patient safety programs. Prevention and control of healthcare associated infections is an important focus at the local, national, and also international levels. Infection prevention and control focuses on evidence-based practices and procedures that can prevent or reduce the risk of transmission of microorganisms. ఇక మనం ముందుకు వెళ్ళే ముందు అసలు ఈ IPC యొక్క ప్రాముఖ్యత ఏంటి అనేది కనుక మనం తెలుసుకోగలిగితే మనకి ఈ విధి విధానాలు రూపకల్పనలో అలాగే వాటిని మన ఇన్స్టిట్యూషన్స్లో ఇంప్లిమెంట్ చేయడానికి చాలా దోహదం చేస్తుంది. మనకి అందరికీ తెలిసినటువంటి విధంగానే ఇన్ఫెక్షన్స్ ఆర్ ఏ లీడింగ్ కాజ్ ఆఫ్ మార్బిడిటీ అండ్ mortality in healthcare settings. Infections cause prolonged hospital stay, which has an impact on costs also. Before the advancements in infection prevention and control, if the patient had a surgery, that is, I am talking about the old times in 16th, 17th, or 18th, or 19th century, it was definite that the patient, even if the surgery was successful, he would die. He would die because of the secondary infection or the sepsis. In the late 19th century, with the development of the germ theory by Louis Pasteur and its subsequent application to surgical sterility by Joseph Lister, surgeons were able to operate with substantially reduced risk of infection. ఆ విధంగా ఈ ఇన్ఫెక్షన్ ప్రివెన్షన్ అండ్ కంట్రోల్ ప్రాక్టీసెస్ మొదలు పెట్టడం వల్ల ఈరోజు మనం మన హెల్త్ కేర్ ఇన్స్టిట్యూషన్స్లో సర్జరీస్ని సక్సెస్ఫుల్గా అలాగే సేఫ్గా చేయటానికి దోహదం చేస్తూ ఉంది. ఇన్ఫెక్షన్ is a major cause of human suffering. Even relatively minor infections can become more serious, leading to a major infection, and can, in some cases, lead to, unfortunately, the patient death. In addition to patient suffering, infections, as we all know, can also cause the distress to the family and friends. In addition, the acquisition of occupationally acquired infections may pose a big risk to healthcare workers, that is all of us. In order to protect patients and staff and to reduce the costs of healthcare associated infections, it is necessary to prevent infections before they occur. Let us take a very quick look at the history of infection prevention and control, and also those people who have significantly contributed to the science and practices of infection prevention and control. If we look at history, even before 18th century, efforts were made at wound prophylaxis. And then the scientists and healthcare workers like Semmelweis, Nightingale, Pasteur, Lister uh, have contributed with their works to improve infection prevention and control as a science, and also contributed to some of the best practices. During the 1950s, epidemic penicillin resistant Staphylococcus aureus infections, especially in hospital nurseries, have captured the global attention and the public attention, and highlighted the importance of techniques to prevent hospital acquired infections, which are now referred to as healthcare associated infections. In the United States of America, the studies which were conducted in 1970s have become a landmark, and also they triggered the rapid evolution of infection prevention and control in the clinical setting. Ongoing surveillance of healthcare associated infections was that time initiated and mandated by the Joint Commission International. If you look at 1980s, the study on efficacy of nosocomial infection control demonstrated that surveillance for healthcare associated infections and infection prevention and control practices that included the trained professionals were effective in reducing healthcare associated infections. This study is popularly known as SENIC study, which, as I told you, is a landmark study which has made a tectonic difference in terms of our understanding of infection prevention and control practices. Then the Center for Disease Control of United States has began the National Nosocomial Infection Surveillance System for reporting all the healthcare associated infections which occur within the healthcare institutions of United States. As a result, an important role developed for hospital epidemiologists and infection control practitioners. During the same time, in United Kingdom, Germany, and other countries also, the infection prevention and control practices started, and they made a way to build further on the IPC as a science, and also building some of the best practices. As you know, from 2000 onwards, with there is an increased accent on patient safety, and the frequency of the epidemics and pandemics which have happened in last 20 years have brought a lot of attention to infection prevention and control, especially the ongoing pandemic, that is COVID-19, has accelerated that process. It is good that I mean to say the silver lining of the current pandemic is that now we got the much needed attention to the infection prevention and control, not only as a science, but also to implement those practices which can reduce the burden of healthcare associated infections. Now, let us look at some of the prominent people who made difference to IPC science and practices. If I had to name those who made a lot of difference, the first among them would be the Florence Nightingale. She is considered the first infection control nurse. Her work with the epidemiologist William Farr in England was one of the first examples in history demonstrating the effectiveness of close collaboration between infection control nurses and hospital epidemiologists. She once stated, I quote her, "It may seem a strange principle to enunciate as the very first requirement in a hospital that it should do the sick no harm." I would repeat, do the sick no harm. That should be our motto while we are delivering our service, while we are delivering our duties within the healthcare institutions. She observed that open windows interfered with the ventilation of the hospital wards and allowed air from the wards to pass into the corridors. Nightingale believed that the respiratory secretions were potentially dangerous, especially among the sick, and that sick should be isolated. Now, let us look at another prominent scientist who had made difference to IPC. He is Ignaz Semmelweis. He is an Hungarian obstetrician who worked in Vienna Hospital. He is credited with first discovering that healthcare providers could transmit disease. As he described the mode of transmission of puerperal sepsis, the death rate was 5 times higher for mothers who delivered in the hospital than mothers who delivered at home. He also witnessed a pathologist die of sepsis after sustaining a scalpel wound while performing an autopsy on a patient with puerperal sepsis. He noted that the pathologist's clinical illness mimicked that of women with puerperal sepsis and identified that not only a scalpel but also physicians' hands contaminated after an autopsy could transmit contaminated material or microorganisms to mothers in labor. He introduced chlorinated lime hand washing into the clinic, staffed by obstetricians and medical students, which has resulted in drastic improvements in rates of maternal mortality. As usual, which happens with most of the innovators, he was ignored and ridiculed by his own colleagues of his time. When Robert Koch's postulate was published in 1890, the germ theory of disease and Semmelweis' theory of transmission from patient to patient were considered finally plausible, but unfortunately, by the time he was not live anymore. Another very prominent scientist and a professor of surgery at Glasgow, Scotland, Joseph Lister, has contributed significantly to the science of IPC. Lister is credited with the beginnings of sterilization in the operation theatre. Before surgery, he sprayed the operating rooms with carbolic acid because he thought that the infections were caused by the dust particles in the air. He, like Semmelweis, was largely ignored by his medical colleagues. But his contributions have made all the difference to the surgeries in the modern healthcare system. Today, fortunately, we don't see that level of surgical site infections, what used to be an order of the day in Lister or Semmelweis time. So now let us look at the infection prevention and control programs. The earliest of these programs were in 1950s. They began as an effort to address the issues like staphylococcus epidemics. During the past 20 years or so, there have been major advances in the field of infection prevention and control. The focus has moved to identifying risks and prevention techniques for various types of healthcare associated infections, including pneumonia, bloodstream infections, urinary tract infections, and surgical site infections. HAIs, or healthcare associated infections, are being caused by pathogens with greater resistance to antimicrobials. There is a major focus on preventing spread of these microbes through antimicrobial stewardship and proven infection prevention and control practices. So now look at, we had been talking about multiple times about HAI, that is healthcare associated infections. Now look at what are they. అసలు ఈ ఆరోగ్య సంరక్షణ సంబంధిత అంటువ్యాధులు అంటే ఏంటి అనేది ఒకసారి మనం చాలా క్లుప్తంగా మాట్లాడుకుందాం. And HAI is an infection that is acquired by a patient during care delivery in a hospital or other healthcare facility that was not present or incubating on admission. This is very important, that it is not present or incubating on admission. Visitors, family members, and healthcare workers can also be affected by healthcare associated infections. HAIs are mostly caused by microorganisms resistant to one or more commonly used antibiotics. Common HAIs include urinary tract infections, pneumonia, bloodstream infections, and surgical site infections. So, healthcare associated infections, if you look at the statistics, these are infections caused by a wide variety of common and unusual bacteria, fungi, viruses, etc. during the course of receiving medical care. Of every 100 hospitalized patients, as per World Health Organization, at any given time, 7 in developed and 10 in developing countries will acquire at least one healthcare associated infection. That is the level of damage what healthcare associated infections can cause to the patients who are under our care. And hence, we definitely need to be very careful about preventing these healthcare associated infections, especially in the maternity wards. This could be a very big problem, especially in intensive care units. It is a significant risk because, as we all know, 30% of patients in ICU are affected by at least one HAI in high income countries, and in low income or medium income countries like ours, it could be even higher than in developed world. So now let us look at what are the common factors which cause the healthcare associated infections. What factors put patients at risk of infection in healthcare settings? Several factors can cause healthcare associated infections. Some of these factors are present regardless of resources available. That means, they can happen even in the countries where there is a significant level of infrastructure development. So, which are they? Which are regardless of resource availability? They are like prolonged and inappropriate use of invasive devices and antibiotics, high risk and sophisticated procedures, insufficient application of standard and isolation practices. In settings where there are limited resources, that is, like our settings, those are poor water, sanitation, waste management, and environmental cleaning, etc., etc. When they are not done properly, they can very significantly contribute to HI. Insufficient equipment, overcrowding, and also poor knowledge of the infection prevention and control practices also can be a major determinant of HI. And last but not the least, that absence of the guidelines, policies, and programs could also significantly increase the incidence of healthcare associated infections. So now let us take a little break and try and answer some of the questions related to whatever we have discussed during last 15 minutes. Here we go, and this is the quiz. Please try and answer as many questions as you can. Thank you. So, welcome back. Hope we have now got the clarity on definitions of HI, IPC. We also could understand a little bit about the history of IPC and also the importance of infection prevention for patient safety. Now let us look at goals, function, and practices of IPC. Primarily, to prevent the spread of infections and consequently to protect patients from HAIs. These goals are relevant to care activities across the spectrum of healthcare settings, including acute care, maternity, and other specialties. Basically, if we had to say it in one line, that is from primary health center to tertiary care. In all the kind of settings, these goals are very relevant. And nowadays, since the home care is becoming a new practice, so these goals are also applicable when the care is provided at homes. So let us very quickly look at what are the functions of IPC. To implement evidence-based practice, standards, and guidelines through setting-specific policies and procedures. That is the first function of IPC. The fundamental functions are applicable to all settings where healthcare is being provided, regardless of the structure or hierarchy of the healthcare system. Major responsibilities would include surveillance, continuous quality improvement, consultation, committee involvement, that is Infection Control Committee involvement, outbreak and isolation management, regulatory compliance, and also the education and awareness. Policies and procedures are typically written and approved by some group like Infection Control Committee, and usually they are shared with pertinent staff. These policies may include cleaning, disinfection, sterilization, waste management, antibiotic use, hand hygiene, isolation, and also other precautions, occupational health, etc. etc. Some of these topics like hand hygiene, biomedical waste, antimicrobial resistance, isolation and transmission based precautions, etc., will be elaborated by colleagues in their lectures during the next few weeks. Now, let us look at what is the practice of IPC today. Practice of IPC is, as you know, is relatively a new science, and it is continuously evolving. Infection prevention and control programs have shown to be both clinically effective and also cost effective, providing important cost savings in terms of fewer HAIs, reduced length of hospital stay, less antimicrobial resistance, and decreased costs of treatment for infections. These activities are generally for all programs. The practices for each function will vary depending on the facility, patient population, and issues identified by the program. So, what are the factors which are involved in healthcare associated infections? They are primarily microorganisms, then the host, the carriers, the environment, and of course the treatment, especially the antimicrobial treatment. So let us look at the chain of infection. The chain of infection, which is a very easy way of comprehending the transmission, is developed by Center for Disease Control USA in 2016. As you all know, certain conditions must be met in order for a microbe or infectious disease to be spread from one person to the other person. This process is known as the chain of infection. There are 6 steps in the chain of infection, and transmission will only take place if all 6 links are intact. That means they are not broken. So now let us look at a little elaborately at each of these components of the chain. The first in the chain is infectious agent or microorganism. That can be virus, bacteria, or fungi, which has the ability to cause the infection or the disease. Then the second component of this chain or second link in this chain is reservoir, or we also call it as a source, a host which allows the microorganism to live and possibly grow and multiply. Humans and animals and the environment can all be reservoirs for microorganisms. Then the next link in the chain is portal of exit, the portal of exit from the reservoir. This describes the way the microorganism leaves the reservoir. This can happen through the mouth if a person coughs or sneezes, through a cut if a person is bleeding, during diaper changes, or when the person goes to the toilet. For example, in the case of a person with flu, this would include coughing and sneezing. In the case of someone with gastroenteritis, microorganisms would be transmitted in the feces or vomit. The next link in the chain which is also very, very important, is the mode of transmission. How the infectious agent is transmitted from one person to the another. It can be in the form of droplets, direct or indirect contact, or through airborne transmission. Another important link in the chain is the portal of entry, a place for the microorganism to get into a new host similar to the portal of exit. This could be landing on a mucous membrane, like for example, in COVID-19, entering through the nostrils, entering, or in other cases, entering via a wound or a tube such as catheter, etc., etc. The next link is susceptible host. It's either a baby, an elderly person, or someone with a weakened immune system that is susceptible to the infectious agent. So, broadly, if we look at, if any of these links are broken, then the infection will not occur. Infection control principles are aimed at breaking one or more links in this chain. I hope you all understood it, and please go through this as many times as you can, so that you can very clearly understand this chain very, very clearly. Now look at some of these key terminologies, that is alcohol-based hand rub, antimicrobial resistance, HAI, we already talked about, the healthcare associated infections, HCW, that is healthcare workers, and then followed by the ICU, which is intensive care unit, IPC is infection prevention and control, LMIC is low and medium income countries. So now let us take a little break again and do a very small assessment. And here you go with a few questions. Please try and answer them. Next 10 minutes, we are going to discuss the World Health Organization guidelines for IPC and the core components prescribed by the expert committee for healthcare without avoidable infections. Protecting patient and healthcare worker lives across the world through excellence in infection prevention and control is the purpose of World Health Organization guidelines. So if you look at the global indicators of IPC, you would see here a classification which is given from A to E, where the countries, as per the WHO, are segregated into those blocks, where each country, depending on their preparedness, are given either A, B, C, D, or E ranking. Unfortunately, India falls into either A or B, which we should be improving over a period of time. So here is an IPC situation worldwide in 2018 and 19. In this slide, you will see the IPC situation worldwide. As you can see, only 15% of the countries today are fully compliant, and rest of the countries, the implementation is a work in progress. As I told you earlier, India is unfortunately into either A or B group. That is a predominant number of countries are falling into this category. I hope with the kind of awareness program which we are conducting now, India should be moving very soon into C, D, or E category. So now let us look at the World Health Organization 2019 global survey on IPC at healthcare facility level. So, if you look at what World Health Organization has done is it has developed an assessment framework which is called as IPCAF, which is a tool to support the implementation of the WHO guidelines on core components of IPC programs at the acute care facility level. In order to do this, the people should be familiar with the contents of these guidelines, and they should be using this IPCAF in a very systematic way in order to get to a baseline assessment. In fact, World Health Organization has proposed 5 steps for implementation of IPC facility programs, which includes preparing for action, baseline assessment, developing and executing an action plan, assessing impact, and then sustaining the program over the long term. In particular, if you look at the IPCAF is a very valuable tool to support step 2 and 4 of this process, which are baseline assessment and also the assessing the impact of the programs, in order to in the context of the action plan. I'm sure you can download this IPCAF scoring format, and you can also do the assessment for your facility so that you can get a fair view about where do you stand today. This is a snapshot of interim results which were published by World Health Organization in 2019. As per this, you can see the scores, which are given. Where do the world stand in terms of each of the core components, which we are going to talk about in the subsequent slides. Why IPC is so important for global health? ప్రపంచ ఆరోగ్యానికి ఐపీసీ ఎందుకు అంత ముఖ్యమైనది? ఎందుకంటే, as discussed earlier, IPC occupies a unique position in the field of patient safety and quality of care, as it is universally relevant to every healthcare worker and patient at every healthcare interaction. Without effective infection prevention and control system, it is impossible to achieve quality healthcare delivery and also the strong healthcare systems. And hence, it is very, very important that to implement the IPC policies within our healthcare institutions. In order to improve the infection prevention and control situation globally, World Health Organization has come out with revised core components in 2016. The World Health Organization core components are a roadmap for how IPC can prevent harm due to healthcare infection and antimicrobial resistance, which is also very quickly becoming a major issue for global health. Now, if we had to translate these guidelines into actions, we definitely need certain components to be in place. What are those? The people is the first component. If we don't have the right kind of human resources, we will not be able to translate these guidelines into action. So, in my opinion, the people are the first and foremost, and these people doing something about the IPC with impact, so we can witness the health outcomes and also the patient safety outcomes within our healthcare institutions. Here are various implementation manuals which were published by World Health Organization. They are freely available. You can download and go through them so that you can get a view of it, and also improve your knowledge curve, and so that you can implement these practices in a good way in your healthcare institution. Now, let us look at the evolution and role of core components for effective IPC programs. As you all know, that guidelines had been evolving as the evidence, that is scientific evidence, was building from research and field experiences. As been mentioned earlier, first guidelines were issued in 2008, and comprehensive revision was done in 2016. But since the 2016 revision was very comprehensive, and most of the countries were feeling helpless actually to implement them at one go, World Health Organization has come out with a minimum requirement for IPC program in 2019, which is currently available. I'm sure this is going to make the process of getting into the right practices easier for those countries who are considered to be at the beginning of the curve. So now let us take a very quick break, and let us do a little bit of assessment. And here you go with the questions. Now, let us take a dive into World Health Organization core components of IPC programs at national and acute healthcare facility level. As mentioned earlier, this is a roadmap for how IPC can prevent harm due to healthcare associated infections and antimicrobial resistance. In revised guidelines, also the principles and central elements have remained the same. The approach has changed a little bit, reflecting more evidence, and some new recommendations are also added with focus on multimodal behavior, WASH and IPC integration, and antimicrobial resistance. And also these new guidelines have given a renewed kind of focus on implementation of these guidelines within low medium income countries who usually have very low resources in order to implement these programs. We shall talk about these things in detail in further slides. So these are 8 basically core components, and there are also about 11 evidence-based recommendations and 3 good practice statements which were given as part of the World Health Organization core components for IPC programs. 3 among these, those which are given in green, are very important for healthcare facility level. Those are the surveillance, multimodal strategies, monitoring, audit, and feedback. Now, let us go into the core components itself. The core component number 1 is the IPC program. Each, as per this as per this component, each healthcare facility should have an IPC program with dedicated and trained team. This is very, very important. The minimum requirement as per 2019 revised guidelines says trained IPC focal point, that is one full-time trained IPC officer, nurse or doctor, as per the recommended ratio of 1:250 beds, with dedicated time to carry out IPC activities in all facilities. And also there had to be a dedicated budget for IPC implementation as per this component. Now moving into the core component 2, This is about the guidelines. At secondary hospital level to which you belong to, the hand hygiene, biomedical waste, environment cleaning, decontamination, standard and transmission based precautions, septic technique for invasive procedures, including surgery, specific SOPs to prevent the most prevalent HIs based on the local context, epidemiology, occupational health is very, very important. Now, moving into the core component 3, this is about education and training, uh, which is the exercise conducted now. Uh, as per this component, the minimum requirement which is suggested by World Health Organization is the IPC training should be imparted for all frontline clinical staff and cleaners upon hire, means at the time of hiring them. This session and the further sessions, as I told, will fall into this category. Now, going into the core component 4, uh, this is about healthcare associated infection surveillance, and this action is very, very important, as I mentioned earlier, for healthcare facility. So, facility based surveillance should be performed using standardized definitions, methods in compliance with national or subnational guidelines or the programs, whatever are the plans, which are mentioned by the government from time to time. So now going into core component 5, this is also very important for action at healthcare facility level. This is about multi-modal strategies. So what is multi-modal strategy? Multi-modal strategy comprises several elements or components, which are usually 3 or more. In fact, usually it is 5, implemented in an integrated way with the aim of improving an outcome and changing the behavior. It includes tools such as bundles and checklists, which are developed by multidisciplinary teams considering the local conditions within your healthcare institution. Looking at core component 6, which is about monitoring or audit of IPC practices and feedback. This is very important in order to achieve behavior change or other process modification, and also to document progress and impact. For example, hand hygiene is an essential process indicator which had to be monitored by 100% of the facilities, irrespective of their setting, because um, that can significantly reduce the risk of healthcare associated infections in any given institution. Now, going into core component 7, it is about workload, staffing, and bed occupancy. Again, minimum requirements are to standardize bed occupancy, establish a system to manage the use of space in the facility, and to establish the standard bed capacity for the facility. Usually, our hospitals are very crowded. Even the maternity hospitals are very crowded. So we had to the extent possible, we had to ensure that no more than one patient per bed. We had to ensure spacing of at least 1 meter between the edges of the beds, and overall occupancy should not exceed the designed total bed capacity of the facility. I know that I may be sounding a little unrealistic for the kind of deficient infrastructure we have, but I think we should be uh, at least making a noise about it, so that over a period of time we can make changes to our system. Uh, Now moving into the next component, which is component 8. It is about built environment, materials, and equipment for IPC. You may not be having a direct role to play, but I think being aware of this would enable you to bring the necessary change within the facility, and also to help your administration in order to make the changes whenever they are renovating the space. Probably you could also become part of the team which is going to suggest the right kind of practices in terms of built environment, materials, and the equipments. Now, the moving into the next slide. Now we summarizing the core components. Let us look at what are the challenges for low and medium income countries in regard to core components. The challenges usually are limited access to qualified and trained IPC professionals, limited human resources, inadequate budgets, implementation challenges, need for adaptation or tailoring to the cultural setting and local context, and according to the available resources, availability of human resources and training, quality microbiology and laboratory support, etc., etc. All these are kind of major challenges, especially in low and medium income countries where the resources are very limited. So in terms of outcomes, they are dependent on multiple factors. We need to be aware resources invested are worth the net gain, irrespective of the context and despite the costs incurred. Not all solutions require additional resources, and some solutions can be low cost, and sometimes probably there are no costs involved actually to make certain changes. So this kind of understanding probably again would help all of us to improve without complaining. The ultimate goal of all these core components is for all countries to achieve implementation or improvement of the full requirements of all core components to effectively reduce healthcare associated infections and antimicrobial resistance. Um, uh, in order to improve the situation in various countries, there are various organizations who are working in collaboration with multiple organizations like World Health Organization, UNICEF, etc., etc. In Indian kind of scenario, also there are various organizations which are working in an endeavor to build the capacity, and IFCI, that is Infection Control Academy, is playing its own role, which is very important in implementation of IPC guidelines and also creating the capacity of infection preventionists. For those of you who want to make infection prevention as a career, you may want to know about PG level diploma program in IPC, which is first of its kind in India and other developing countries, and this is offered by IFCI. You can actually follow this link and then get more information about it. So now let us take again a very quick break and do the assessment. And here you go with the questions. So now let us summarize what we have discussed in the last 40-minute plus. In summary, let me take 2 minutes and emphasize on some of those topics which we have covered today. And I would like to again emphasize that infections are a leading cause of morbidity and mortality in healthcare settings. Infection prevention and control focuses on evidence-based practices and procedures that can prevent or reduce the risk of transmission of microorganisms to healthcare providers, clients, patients, residents, and visitors. Understanding how infections occur and how different microorganisms spread is crucial to preventing infection. Infection prevention and control is everyone's responsibility, and all healthcare workers have an important role to play in this. Use of multimodal strategies, at the very least, to implement interventions to improve each one of the standard and transmission based precautions and triage. So, uh, hand hygiene is an essential process indicator to be monitored. We all need to build it, teach it, check it, sell it, and live it. There are some things like sell it. It may look like more a marketing jargon, but World Health Organization has very consciously used the word sell it because we all need to sell it to our colleagues, our managers, our superiors, etc., etc. Our goal should be to achieve implementation or improvement of the full requirements of all core components to effectively reduce HIs and AMRs. The eight core components of IPC are the wheels of the cart that will ensure patients a safe journey while in a healthcare facility, especially in our healthcare settings where infection prevention and control is limited or does not exist. It is very critical to start this journey by ensuring that at least minimum requirements for infection prevention and control are in place. So, here in the next slide, you would see the summary in Telugu. తెలుగులో ఇక్కడ మనం మాట్లాడుకున్న దాని గురించి మళ్ళీ ఇంకొకసారి ఇవ్వటం జరిగింది. నేను ఇవంతా మళ్ళీ మీకు చదివి వినిపించను. ఒకసారి మీ అంతటి మీరే దాన్ని చదవండి. అలాగే మున్ముందు మీరు ఈ ఐపీసీ గురించి ఇంకా ఎక్కువ విషయాలు తెలుసుకోవటానికి, అలాగే మీ నాలెడ్జ్ని ఇంప్రూవ్ చేసుకోవటానికి, మీ సామర్థ్యాన్ని పెంచుకోవటానికి ఇక్కడ కొన్ని రిఫరెన్సెస్ ఇవ్వటం జరిగింది. వీటిని మీరు డౌన్లోడ్ చేసుకొని చదువుకొని మీ యొక్క నాలెడ్జ్ని ఇంప్రూవ్ చేసుకోవటానికి అవకాశం ఉంటుందని నేను భావిస్తున్నాను. సో hope this session has helped you in order to understand the infection prevention and control as a science and also as a core thing which had to be implemented within the healthcare institutions. Now, I hope the first lecture, which is just being delivered, has set the tone for further 9 lectures which are going to happen over a period of next few weeks. Let me again wish you all the best, happy learning, and hope to see you guys very soon. Thank you. Have a good time.